The free medical brace lie. How a $0 Medicare perk triggers a $40,000 identity drain. A free Medicare brace sounds harmless, right? Say yes once, and you can trigger years of denied care and padded billing you never see coming. The top 1% who catch this early don't fall for the brace. They spot the identity drain. Here's the lie. Dollar back brace, no copay. Here's the trap. Your Medicare number gets used like a credit card, and the charges stack while your future claims get blocked. One quick okay can snowball into $40,000 in fake claims and real denials. This isn't rare noise. Medicare fraud is estimated around $60 billion a year, and your number fuels it. In the next few minutes, I'll show you exactly how the scam works, how to undo the damage fast, and the return to sender move that stops charges cold. This isn't about a brace. It's about protecting your Medicare identity. The hidden cost of free. Let's start with the why, because the cost of free isn't the price tag. It's what it burns. The first hit is emotional. It's embarrassing to tell your doctor you said yes to a call. It's scary to see bills with suppliers you've never heard of, and it's frustrating when you try to fix it and feel like nobody's listening. That fear keeps people quiet, and silence is exactly what mills rely on to keep billing. The second hit is opportunity cost. Durable medical equipment has replacement windows. If a back, knee, or ankle brace shows up in your history, your next real device can be denied under same or similar rules for months or years. When you actually need care, the system thinks you already got it. Here's the belief break. It's free, so it can't hurt. Wrong. It burns your benefit history. Your Medicare number works like a medical credit card. When you share it, suppliers can submit claims to Medicare under your identity. Scammers know this, so they dangle no copay to lower your guard and harvest your number, your address, your doctor's name, and keywords like chronic pain. That's enough to push paperwork that looks legitimate to claim processors. Now, the good news, the sentinel effect. When beneficiaries and caregivers actively read their Medicare summary notices, make unknown supplier lists, and call Senior Medicare Patrol, fraud drops. Visible oversight shortens billing runs. Scammers move on when they see you're watching. I've seen this play out. The moment someone starts logging calls, saving labels, and reporting fast, the bogus claims stop appearing and older ones get reversed sooner. This is a behavior signal. Consistent audits, refusals, and reports trigger reviews and repayment demands. So mills abandon vigilant targets. Social proof matters. Senior Medicare Patrol programs report tens of millions in combined savings and recoveries each year. Recent program data shows more than $35 million in recoveries and cost avoidance in a single year. That's traction, not the total scale, but it proves that timely reports move dollars back and shut down repeat runs. Why does this work on so many smart people? Because it echoes a real event. In 2018 to 2019, Medicare did replace cards to remove Social Security numbers. Scammers still mimic that change with the plastic card with a security chip pitch. It feels modern and safe, so verification questions don't raise alarms. Once they get your number, they funnel it to a telehealth mill, then to a DME supplier. And the billing spree starts. If you remember nothing else, remember this. Guard your Medicare number, read your MSNs like a bank statement, and act quickly. Small steps today prevent denials tomorrow. Now, let me show you the exact lie they use to get your number. The new card lie that opens the door. Here's the exact script they're using right now. The phone rings. Hi, this is Medicare Outreach. We're issuing a new plastic card with a security chip to protect your benefits. It's free and pre-approved. I just need to verify your Medicare number, your address, and your primary care doctor so we can ship it. There's no copay, and this is a limited time wellness upgrade. Can you confirm those details for me? That's it. Short, friendly, and designed to sound like a courtesy call. Why does it work? It echoes a real memory. In 2018 and 2019, Medicare replaced cards to remove Social Security numbers. So new card feels familiar. Add the word chip, and it sounds safer, like your bank card, even though Medicare does not issue chip cards. Toss in no copay and pre-approved, and your guard drops. You're not giving information, you're confirming. What are they actually collecting? For things that matter: your Medicare number, your address, your doctor's name, and any pain or condition keywords you casually mention, like sciatica, knee pain, or neuropathy. Those keywords become diagnosis bait. They'll attach them to boilerplate visit notes later. Now, the hidden funnel kicks in. The caller passes your info to a telehealth mill. You might get a quick follow-up call. A licensed provider will review your wellness upgrade in a brief televisit. This ensures your card and benefits stay active. The visit is a 30-second checkbox script. Rate your back pain 1 to 10. Does it affect daily activities? They capture a diagnosis code and a minimal face-to-face note. On paper, that's enough to claim medical necessity. From there, your data flows to a DME supplier, often one you've never heard of in a different state. They pick a device that matches the diagnosis and is easy to ship: a back brace, knee brace, ankle-foot orthosis, or wrist splint. Then they bill Medicare under a DME HCPCS E-code. If they think they can bill more, they'll add topical creams, orthotics, or even toss your info to a lab for screening panels. No one asks you again. The chip card story was the single consent moment they needed to extract your details and fabricate medical necessity. Here's the twist that most people miss. The scammer doesn't need you to use the device. They need a shipment record. Once a label prints and a box moves, billing starts. Even worse, the moment that first claim hits, it can block future legitimate claims under same or similar rules for months or years. That's the denial that shows up later when you actually need care. Let me show you the telltale phrases so you can hang up fast. New plastic Medicare card with a chip. Pre-approved wellness upgrade. No copay. We just need to verify your Medicare number to mail it. Limited time replacement to keep benefits active. Your counterscript is simple. I don't confirm Medicare information by phone. Mail me official notices. Then hang up. If they persist, repeat it. Every extra second you stay on the line, they're probing for crumbs, doctor names, conditions, anything to legitimize a claim later. The reason this works is paperwork, not medicine. On paper, it looks adequate. In real life, it's a data grab that opens the billing door. Next, you'll meet Arthur, and you'll see how one okay turned into a denial when he actually needed a brace. Arthur's denial trap: intention, obstacle, stakes, resolution. Arthur's a straight shooter, 72, retired machinist, still mowing his lawn and doing light yard work. 2 summers ago, he got that new plastic Medicare card with a chip call, then a second call offering a $1 back brace. He wasn't trying to game the system. He thought it might help when his back flared after raking. He said, okay, a box arrived. He never wore the brace. It sat in the hall closet. Fast forward 22 months. He slips on a wet step, bangs his knee, and now he actually needs a medically fitted knee brace so he can do PT and walk without pain. His orthopedist writes the order. It should be simple. Instead, the claim pings back denied. The code line reads like alphabet soup, but the pharmacist circles it for him. Same or similar. On the remittance, it translates to reason code 97 with Remark code N390. Here's what that means in plain English. The system thinks Arthur already got a similar device within the replacement window. For many DME items, Medicare's same or similar rule locks you out for 13 to 36 months, sometimes longer depending on the HCPCS E-codes and useful lifetime rules. On paper, Arthur has a brace on file, so the new brace is included in a prior allowance. No payment, no device. Pain continues. Arthur does what most people do first. He calls the supplier listed on the denial. They've never heard of his orthopedist. They read a different supplier name back to him in another state. He pulls his Medicare summary notices out of a shoebox. Now it gets weird. He sees multiple suppliers he doesn't recognize and charges tied to dates he never received anything. The closet brace, that one lines up, but there are refills and even a wrist splint he never ordered. This is the moment that clicks. The denial isn't about his knee today. It's about identity used yesterday. That chip card call and the quick televisit created a paper trail, a checkbox pain scale, a diagnosis code, and shipment records. It looks legitimate to a claims editor. That's why the system said no. Now, here's how he turned it around. First, he audited 3 lines on every MSN, who billed what item code, and the date shipped/dispensed. He starred anything outside his state or doctor network. He photographed the old brace label from the closet and wrote, "Unsolicited DME, refused use" on a note, then signed and dated it as a statement. Second, he opened a case with Senior Medicare Patrol and called 1-800 Medicare to request a fraud tag and claim hold on the suspicious suppliers. He gave dates, suppliers, and those HCPCS E-codes he could read from the MSNs. Now, there's a paper trail in his favor. Third, he called his orthopedist's office and asked for a letter that stated medical necessity for the knee brace and confirmed there'd been no prior knee device issued or used. He attached that to a Level 1 redetermination request with his DME MAC within the 120-day window. He included his sworn statement, SMP case number, and screenshots of the suspect MSNs. He also asked the hospital DME for a temporary loaner brace while the appeal processed. Here's the part most people miss. Arthur also demanded the face-to-face visit notes from the unknown supplier's doctor. The Mills notes were generic, a 30-second checkbox, no exam findings. That weakness helped the reviewer see the pattern. Finally, he used a simple call script with every contact. "I did not consent to these items, I did not receive or use them, and I'm requesting removal from my record and reversal of charges." Calm, repeatable, written down next to the phone. Payoff. The denial reopened. The knee brace got approved with a temporary authorization, and several bogus DME lines were reversed. More important, the Mills stopped. Once Arthur started logging, reporting, and pushing for notes, the billing run died out. The closet brace became evidence instead of a roadblock, and he walked back into PT, wearing a brace that actually fit. The $40,000 math. How small items snowball. Let's unpack the math that turned Arthur's one okay into years of trouble, because this is where small items quietly add up to real dollars and real denials. It usually starts with a modest claim, like a $500 back brace. On its own, that's annoying, not devastating, but Mills rarely stop at one. Once your Medicare number is active, they layer phantom items that fit the same narrative: diabetic test strips you never use, topical pain creams, orthotics, wrist splints, even genetic screening panels. Each line looks reasonable in isolation. Together, they turn your record into a supply closet you never ordered. Now here's where the gear shift happens. Recurring cycles. A lot of DME and supply codes are billable on a refill schedule. That means monthly, quarterly, or as needed shipments get pushed through without anyone checking your doorstep. No box arrives, but refills show up on your Medicare summary notice. If you're not reading your MSNs, those repeats stack fast. The second multiplier is trial build equipment. Scooters and other mobility items sometimes appear as short-term rentals that were evaluated or trialed. In many cases, there's no real evaluation, just a checkbox. The claim hits anyway. Even small monthly rental amounts can creep along for months before anyone blinks. Here's the rule that locks in the damage. Same or similar. Most bracing and orthotics fall under MIPOs, E-codes, and many have replacement windows that run from 13 to 36 months, with typical reasonable useful lifetimes often spanning 3 to 5 years under Medicare policy. Once any E-code posts in your file, a different supplier can argue your next brace is included or already provided. That's how a $500 fake back brace can block a legitimate $900 knee brace 20 months later. The money is one problem. The denial of needed care is worse. Add in lab plays, and you see the snowball. Genetic testing panels often bill as bundle G codes. A single panel might run hundreds to over $1,000. If a mill links 2 or 3 panels across a year using the same televisit notes, you've now stacked thousands without a single office visit. Oxygen scams are another high-dollar lane. We'll flag more in the audit section, but rentals like E0424, stationary gaseous oxygen system rental, and E0439, portable liquid oxygen system rental, can appear as long-running monthly charges. If you never used oxygen, that's pure burn. If you did, overlapping rentals from different suppliers blow up costs even faster. Capped rental rules spread payments over months, which can mask abuse during a quick review. So, how does this hit $40,000? Think in episodes. Episode 1, $500 brace, $1,200 in creams, $900 in orthotics, $2,400 in refills, and a $1,200 genetic panel. Now you're near $6,200. Episode 2, a year later, repeats the brace lane with knee and wrist items plus more labs, another $7,000 to $10,000. Episode 3 adds a scooter, trial, and oxygen rentals that run for months. There's another $8,000 to $12,000. Across a few years and a couple of mills sharing your number, crossing $40,000 isn't rare. It's routine. The toughest part is the timing. Every bogus claim also resets replacement clocks and triggers future denials. You pay twice. Once in dollars, Medicare shells out. Again, when your real care gets blocked under same or similar. The fix is speed and documentation. Catch refills in month 1, not month 12. Refuse boxes the day they arrive. Push for redeterminations before replacement windows expire. Every week you save cuts charges and shortens denial windows. And that's how you stop the snowball before it buries you. The Dr. Mill, 30 seconds to medical necessity. Now, let's pull back the curtain on the rubber stamp that makes bad billing look good, the Dr. Mill. I'm not talking about your primary care doctor. I'm talking about pop-up televisit shops built to generate medical necessity in under a minute. Their intake sounds caring. Rate your pain 1 to 10. Does it limit walking or sleep? Check, check, check. No physical exam. No palpation. No range of motion test. Just enough boxes ticked to anchor a diagnosis code. Here's why it slides through. Medicare pays claims based on documentation, not vibes. If a chart note shows a complaint, a brief history, and a diagnosis linked to an item, it often looks adequate on paper. That's the crack the mills widen. They use leased NPI numbers from providers who sign hundreds a day. Volume is the business model. The more signatures, the more devices justified, the more codes pushed. A common pattern goes like this. The mill uses a template. Patient reports chronic low back pain. Severity 7/10, worsened by activity, improved with rest. Interferes with activities of daily living. Recommending lumbar orthosis for stabilization. It takes 30 seconds to read and 5 to sign. The note never references your chart, meds, recent imaging, or prior conservative care. But it hits the buzzwords: chronic, interferes, stabilization. Claims editors see a complete story. You see a device you didn't ask for. Now, here's where most people mess up. They assume if a doctor signed it, it must be valid. Mills bank on that deference. but you're allowed to ask for the proof behind any device tied to your name. Your counter is simple and powerful. Ask the supplier and any listed provider for the visit notes and proof of a real face-to-face encounter. If they can't produce detailed notes, date, duration, exam elements, and a care plan that actually references you, flag it. What should the notes look like? At minimum, there should be a documented exam or legitimate telehealth evaluation that ties symptoms to function, references past treatment, and explains why this exact item is necessary now. For DME, Medicare expects more than a pain score. There should be rationale. Tried physical therapy, used OTC supports, failed conservative measures, and now needs a specific orthosis with features X and Y. Boilerplate without you in it is a red flag. Let me show you exactly how to push back. When a device appears on your MSN, call the supplier and say, "Send me the prescribing provider's signed notes and the order with HCPCS code and modifiers." Then call that provider's office. "I need the full telehealth documentation for my visit date, duration, exam, and plan." If they hesitate, remind them you're the patient of record on a billed service. 2 outcomes help you. 1, the mill can't produce adequate notes. That weakens future claims and supports reversals. 2, the notes reveal a checkbox script that doesn't match your reality. That mismatch strengthens your redetermination and any fraud report with SMP. Once you nail this, everything else clicks, because the game changer nobody talks about is that bad paperwork can be beaten by good paperwork. You don't need drama. You need dates, names, and notes that actually describe you. Coming up, we'll read your Medicare summary notice like a bank statement and spot the codes that don't belong. The MSN audit. Read it like a bank statement. Let's turn your Medicare summary notice into your monthly fraud radar. Treat it like a bank statement. You're not reading for fun, you're scanning for errors that cost you money or block your care. One habit makes this simple: the 3-line audit. For every line item, check 3 things: who billed, what item, and when it was shipped or dispensed. If any one of those looks off, you flag it immediately. Start with who billed. Names you don't recognize, suppliers in distant states, or companies that don't match your doctor's referral are red flags. Make an unknown provider list on a notepad or in your phone. Every time you see a new name you don't trust, it goes on that list with the date and the dollar amount. Next, what item? Look for DME E-codes. These are the braces, orthotics, wheelchairs, and oxygen equipment. You'll often see a description plus a code in the E010, E800 range. If you've never received an item, or it's a duplicate of something you already own, star it. Add lab, G codes too. These are common for bundled genetic panels. One panel can cost hundreds or more, so a phantom lab can burn through benefits fast. Now, the date. Shipped or dispensed dates should match reality. If a brace shows shipped while you were out of town, or a refill appears for a month you didn't get a shipment, that's a billing pattern, not a mistake. Document it. Here's the piece that saves people thousands: oxygen rentals. 2 specific codes show up in a lot of fraud runs: E0424 for stationary gaseous oxygen system rental, and E0439 for portable liquid oxygen system rental. If you see either and you're not on oxygen, that's a hard stop. If you are on oxygen, make sure there aren't overlapping rentals from different suppliers. Under Medicare's capped rental structure, payments are spread across months. So mills try to tuck their claims under that umbrella. Once you've scanned the page, connect dots to the same or similar risk. If you see a brace or orthotic E-code posted in the last 13 to 36 months, expect that to trigger a denial if you later need a new device in the same category. That's where Reason Code 97 and Remark Code and 390 appear on remittances. Basically, this is already covered. When you catch an E-code you didn't order, you're preventing a future no. Okay, so how do you act on a red flag? 3 quick steps. 1. Circle the suspect line on your MSN and write the supplier name, code, and date on your unknown provider list. 2. Call the supplier and ask for the proof, order, signed provider notes, and proof of delivery with tracking. If they can't produce it, you note that. 3. Report it. Call 1-800 Medicare and Senior Medicare Patrol and give them your notes. Ask Medicare to add a fraud tag and hold if possible. A few common patterns to watch for. Monthly refills for supplies you never got. These run quiet until you notice the rhythm. Bundled genetic tests. Billed repeatedly without a new order or visit notes. Oxygen rentals starting out of nowhere or overlapping with your legitimate equipment. Brace claims from a state you've never visited. 2 quick pro tips. First, keep a simple paper folder or binder. Tape mailing labels, print tracking, and slip in your MSN pages with your circles and notes. Second, set a monthly reminder. MSN Day, 15 minutes to scan, star, and, if needed, call. The reason this works is momentum. The earlier you catch it, the shorter the billing run, and the easier the reversal. And when suppliers see you asking for notes and proof of delivery, they move on. That's the sentinel effect in action. Now, if a box shows up at your door, we shift from audit to action. There's a right way to refuse it, so the charge dies on contact. That return to sender protocol is coming up next. When a surprise box lands on your porch, your goal is simple. Create clean, undeniable proof that you never accepted it. That proof kills the charge before it grows legs. Here's the play, step by step, exactly how I teach families to do it. First move, don't open the box. Leave the tape intact. A sealed package is your best evidence. Grab your phone and take 3 quick photos. The full shipping label with your name and address visible, the tracking number close up, and a wide shot of the unopened box on your doorstep or kitchen table. If there's a packing slip in a clear pouch, photograph that too without removing it. Now, mark the refusal. With a thick pen, write refused, unsolicited DME next to the label. Keep it short, all caps. This tells the carrier and the supplier you never took possession. If the delivery driver is still nearby, hand it right back and ask for a refusal scan. If not, place the box at your door for the next pickup and schedule a carrier pickup using the tracking number. Next, make one and only one call to the supplier listed on the label. Calm voice, short script. I did not order this device. I refuse delivery. Mark my account as no prior consent and stop all shipments. Ask for the rep's name and a reference number. Write the date, time, and that number on a sticky note and tape it to a printout of the label photo. If they try to keep you talking, repeat the script and end the call. You're not debating medical necessity here. You're documenting refusal. Then, file your reports. Call 1-800 Medicare and ask to add a potential fraud tag. And hold on claims tied to that supplier while they review. Give the tracking number, ship date, and your short description. Unsolicited DME, refused unopened. Next, contact your local Senior Medicare Patrol and open a case. Email them the photos and the reference number from your supplier call. You've now created a paper trail in 2 systems. Loop in the carrier. Use the tracking portal to request a refusal scan or return to sender status update. If a driver picks it up, ask them to note refused, unopened on their handheld device. Take a photo of the pickup if you can. These little receipts matter later if a claim sneaks through and you need to prove non-delivery. Build your folder in under 5 minutes. Print the shipping label photo, the tracking page, and a 1-page log that lists date received, supplier name, tracking number, refusal written on box, supplier call reference, Medicare call reference, and SMP case number. Clip them together and drop it in your binder. This folder becomes Exhibit A in any redetermination or plan appeal. 2 common mistakes to avoid. 1. Don't throw the box away. Without proof of refusal, suppliers argue it was delivered and used. 2, don't agree to try the device or a courtesy replacement. That language can reset the clock and open a new billing run. Stick to refused, unsolicited, no prior consent. If a second box shows up, repeat the process and add the new tracking to the same SMP case. Patterns matter. 3 refusals tied to one supplier look like a billing run, not a misunderstanding. And when suppliers see clean refusals, photos, and case numbers, they move on to softer targets. This protocol feels basic, but it's powerful because it flips the burden. Instead of you proving a negative months later, your paperwork proves non-acceptance today. That stops modifiers from being abused, shortens appeal timelines, and keeps your benefit windows clean. Now that you can kill a bad shipment on contact, let's escalate with speed. The 7-day dispute sprint that reverses charges before they stick. Rapid response. 7-day dispute sprint. You've refused the box. Now we move fast. 7 days, 1 task per day. Keep your binder open and your scripts handy. This sprint is about freezing claims before they age in. Day 1, call 1-800 Medicare. Say, I'm reporting unsolicited DME tied to my Medicare number. I refused delivery, and I'm requesting a fraud tag and a temporary claim hold for this supplier. Read the supplier name, HCPCS code if you have it, tracking number, and ship date. Ask the rep to read back your case reference number. Write it down. Before you hang up, ask where to submit your photos. If they provide a fax or upload link, send the label and tracking screenshots today. Day 2, contact Senior Medicare Patrol. Open a case and email your evidence. Photos, your Medicare case number, supplier call reference, and your short statement. Unsolicited device, unopened, refused, no prior consent. Ask for guidance on local DME patterns and whether this supplier is active in your state. SMP's presence applies pressure. Put their case number in your binder. Day 3, if you're on Medicare Advantage, call your plan's member services. Ask them to flag the supplier, initiate an internal fraud review, and place a claims hold pending documentation. If you're on Original Medicare, call your DME MAC. Jurisdiction. Say, I'm requesting a review and hold on claims from supplier due to unsolicited DME and documented refusal. Get a reference ID. Note it. Ask how to submit your proof of non-delivery. Day 4, demand the paperwork from the source. Call the supplier and request, in writing, the prescribing provider's signed order, the telehealth or face-to-face notes, and proof of delivery with tracking and a signature. If they say it was left at door, that's not a signature. Note that if they mention an RA replacement, ask for documentation proving loss or irreparable damage, and the incident date. No evidence, no RA. Email your request so there's a timestamp trail. Day 5, protect your identity footprint. File an FTC identity theft report at identitytheft.gov and select medical identity theft. Save the report number. Then submit a CMS fraud complaint using your Medicare case details, supplier name, and a concise timeline. This does 2 things. It documents intent, and it links your dispute across systems that investigators see. Day 6, close open doors. Call any pharmacies linked to mail orders and freeze all auto-ship programs you don't control. Revoke any telehealth consent forms you didn't sign with your primary care clinic. Tell your PCP's office to add a chart note. Tele-DME only via PCP referral. If you're on an Advantage plan, ask member services to disable auto authorization for DME without an in-network PCP referral. Day 7, follow up and confirm movement. Call Medicare back, reference your case, and ask, have any claims from supplier been received? Are they on hold? What's the next step? Do the same with SMP and your plan or DME MAC. If a claim already posted, request the Level 1 Redetermination form or portal link. Attach your refusal photos, the supplier's lack of proof of delivery, your SMP and FTC report numbers, and your PCP letter if you have it. Ask for a temporary authorization or a loaner device if a denial is blocking care right now. 2 Pro moves tighten the loop. First, send yourself an email with the subject Medicare Dispute Sprint, today's date, and paste your entire log, dates, names, reference numbers, and actions. That becomes a searchable record you can pull up on any call. Second, set calendar reminders for 14 and 30 days to recheck your Medicare summary notice and portal for any new activity from the supplier. Now, common snags. If a rep tells you they can't place a hold, ask them to document your report and escalate to their fraud or program integrity team. If a supplier offers a courtesy replacement, decline. Acceptance language can reset clocks. And if anyone claims you confirmed details by phone, ask for the recording or transcript. Mills rarely have them. This sprint works because speed beats volume. You're freezing claims, building evidence, and forcing documentation when the paper is still fresh. By next week, you'll have holds in place, cases open, and the path cleared for appeals if needed. Lockdown, preventive settings, and scripts. Prevention is lighter than appeals, so let's harden your settings now. Start with your phone. Tape a short script next to it. I don't confirm Medicare information by phone. Remove me from your list. That's it. If they push, repeat it and hang up. Add one more line for persistence. Mail official notices only. You're creating a reflex, not a debate. Next, set call controls. On your cell, whitelist family, your PCP, your pharmacy, and your plan. Block unknown callers by default, and let voicemail filter the rest. Once a week, scan missed calls. Anything suspicious goes on your do not answer list. On landlines, enable your carrier's caller ID screening and require first-time callers to state their name. Scammers hate gates. Now lock down authorizations. If you're on Medicare Advantage, call Member Services and say, disable auto authorization for DME unless it's ordered by my in-network PCP. Ask them to note your file and send written confirmation. For original Medicare, call your primary DME suppliers and instruct no orders or refills without a signed PCP referral and my verbal confirmation on file. You want 2 locks, physician and you. Add a standing order to your medical record. At your next PCP visit, ask them to place this note on your chart. Tele-DME only via PCP referral. No third-party DME orders accepted without in-person or scheduled telehealth evaluation. Have them print the after-visit summary that shows the note. Take a photo and put it in your binder. When a supplier claims the doctor approved it, this note contradicts them. Tighten pharmacy profiles. Call mail order and local pharmacies. Turn off all auto-ship features except the meds you personally approve. Add a PIN to the account. If available, ask them to reject any new prescriber until you confirm. If they say they can't, tell them to annotate your profile with patient requires verbal authorization for any new prescriber or device. Email. Discipline helps too. Create a rule that shunts unknown health or benefits upgrade emails into a review folder. Scan weekly. Never click device claim links. If a message looks official, call the number on your plan card, not the email's number. Make one day your defense day. Once a year, schedule a 30-minute Medicare identity tune-up. Here's the checklist. Review the last 12 months of MSNs. Purge any unknown suppliers from your contacts. Verify your plan's DME settings and refresh your call blocks. If you've had 2 incidents in a year, ask Social Security for a replacement Medicare card number due to suspected medical identity theft. It's paperwork, but it resets the target. Create a quick access kit near your front door. A marker, tape, a refusal stamp or sticky, and a printed mini-script. Refused, unsolicited DME. When a box shows up, you don't hunt for tools, you execute. Beside the phone, keep your one-page call log. Date, time, who, reference number, outcome. Small systems beat big scams. Finally, rehearse. Do one dry run with a family member acting as a Medicare outreach caller. Practice your script and the hang up. It sounds silly until the real call hits and your hands shake a little. Muscle memory wins. Lockdown isn't about living paranoid. It's about pre-deciding. When your defaults are set, scams bounce. And when something slips through, your scripts and settings shorten the fight from months to minutes. When care is denied, appeal and override. If your claim gets denied, don't panic, shift into appeal mode. Start by getting the exact denial language. Ask the supplier or your plan for the remittance details and modifiers. You're often looking at a same or similar denial flagged by reason code 97 with Remark code N390, or you'll see KH/KR modifiers tied to capped rentals or replacement situations. Write those down. Codes tell you which rule blocked you. Now, lock in your timeline. You generally have 120 days to file a Level 1 redetermination with your DME MAC or with your Medicare Advantage plan through their internal process, which follows its own deadlines. Put day 0 on your calendar. You're going to build a clean, simple file that wins on paper. Here's your packet checklist. Your appeal form or letter. 1 page, clear ask. Please overturn this denial and approve device HCPCS code, if known due to medical necessity. Include your Medicare number, dates, and the denial codes. Proof you never received the same or similar item. Photos of refused boxes, tracking pages, refused unopened notes, and any carrier refusal scans. If it was an old shipment you never used, include a signed statement. Item never used, unsolicited with dates, and a label photo if you have it. Doctor letter. Ask your prescribing clinician for a brief letter on letterhead. It should say, your diagnosis, why the device is medically necessary now, prior conservative treatments tried, and a clear statement that no prior device of the same category was provided or used. Dates matter. Tie it to your current condition. Documentation trail. Medicare call reference numbers, SMP case number, and your FDC/CMS fraud report numbers if identity misuse is involved. This links your appeal to active program integrity flags. MSN screenshots, circle suspect E-codes that triggered same or similar. If a past code belongs to a supplier you didn't use, highlight it and add a sticky note. Unknown supplier, disputed. Before you submit, chase the supplier's paperwork. Email them and request the prescribing provider's signed order, the telehealth or face-to-face visit notes, and proof of delivery. If they claim it's a replacement, listen for the RA modifier. RA means replacement of a DME item. That's legitimate only if the original was lost, stolen, or irreparably damaged in a specific incident with documentation. Demand specifics. Incident date, what happened, and why replacement was necessary. No evidence, no valid RA. If they can't produce POD with signature or credible notes, say so in your appeal. Supplier failed to produce adequate proof of delivery and medical necessity. While your appeal is pending, protect your care. Ask your hospital DME or plan for a temporary loaner device. Use this script. This denial is under redetermination. Here's my case number. My doctor confirms medical necessity. I need a loaner to start treatment while we wait. Plans and facilities often have a path for this when therapy can't wait. 2 quick boosters strengthen your case. First, attach a copy of your PCP chart note that says tele-DME only via PCP referral, no third-party orders without evaluation. That contradicts any mill notes. Second, add a short timeline page. Bullet the dates. Injury or need, doctor visit, order written, denial received, documents requested, reports filed. Reviewers love clean timelines. Common pushbacks and counters. We show a prior device in window. Counter. Attached refusal proof and sworn statement. Supplier failed to show signed delivery. Prior line is disputed identity use. Replacement claimed under RA. Counter, no incident documentation provided. RA, misuse to bypass same or similar. See attached request and supplier's non-response. Insufficient medical necessity. Counter, doctor letter and visit notes attached. Conservative measures failed. Brace features meet current functional need. Submit your packet by the portal or certified mail. Keep copies in your binder. Set a 30-day reminder to follow up. And if you're on Advantage, track their internal deadlines. If they miss them, you may escalate to an independent review entity. Last piece, keep calling for the Mills notes. If the template is thin, 30 seconds, no exam, add that to your file. Bad paperwork loses to good paperwork. Your goal isn't a fight, it's a record that makes approval the obvious choice. The core fix, reclaim your Medicare identity. You've stopped the bleeding. Now we reset the identity that scammers touched so they can't reuse it. Think of this as changing the locks on your medical house. Start with your card. If you've had multiple bogus suppliers or repeat hits after refusals, request a replacement Medicare card and number due to suspected medical identity theft. Call 1-800-Medicare and say, I need a new Medicare beneficiary identifier because my number's been used without consent. Ask what documents they need and where to provide your FTC report number and SMP case. When the new card arrives, store the old one and switch every provider to the new number deliberately, not all at once without a record. Next, clean your provider network. Make a list of every legitimate provider you actually use. PCP, specialists, hospital DME, pharmacy, and your Medicare Advantage plan if applicable. Call each office and update your new Medicare number. While you're on the line, add a chart note. Tele-DME only via PCP referral. No DME orders without in-person or scheduled telehealth evaluation. Ask them to print or portal message an after visit summary showing that note and file it in your binder. This closes a common mill door. Purge bogus suppliers from your record. Call the suppliers listed in your unknown provider list and state, remove me from your system. Do not ship or bill. I'm filing fraud reports. Ask them to send written confirmation they've closed your profile. If your plan shows them as in-network providers of record, ask your plan to block them from auto-authorization tied to your profile. Lock pharmacy profiles. Call mail order and local pharmacies and add 2 safeguards. Turn off all auto ship except meds you approve and add a verbal PIN for new prescribers or devices. Request a note. No new DME or supplies without patient verbal okay. If you use a caregiver, add them with authorization so they can enforce these rules. Replace telehealth consents. Any televisit you didn't schedule is a risk. Ask your PCP and regular specialists to refresh consent forms and list your approved telehealth platforms. Decline blanket consents that let third parties initiate device orders. If your plan offers remote monitoring or equipment programs, opt in only through your PCP's office, never a cold call. Centralize the paper. Build one binder. Front page is your master log. List case numbers from Medicare, SMP, your plan or DME MAC, plus your FDC and CMS complaints. Add a contact sheet with the fraud department numbers and your reference IDs. Behind that, keep tabs. MSNs with circles and notes, refusal folders, provider letters, and timelines for each dispute or appeal. One place, everything. It's how you win reviews quickly. Now, tell your circle. If you have a spouse, adult child, or caregiver helping, get HIPAA releases and plan representative authorizations on file so they can speak on your behalf. Share the phone scripts and the monthly MSN routine. 2 eyes on the account double the sentinel effect and cut billing runs short. Finally, reset your defaults. Keep your door kit ready. Keep your call script by the phone and set that monthly MSN reminder. A new number plus documented guardrails turns you from an easy mark into a hard stop. And once your records reflect those boundaries, mills tend to disappear because the risk of non-payment and clawbacks three rises. Fast wins. Story A, the $3,200 stop in 7 days. Maria, 68, started seeing diabetic supplies on her MSN, test strips and lancets she didn't use. Total billed, over 3 months, $3,200. Why this mattered? She isn't diabetic, and repeat supply billing can run indefinitely and trigger same or similar flags for real devices later. What she did was simple. She refused the next surprise box at the door, wrote refused, unsolicited DME on the label, snapped photos of the shipping label and tracking, and asked the carrier for a refusal scan. Then she opened an SMP case and called 1-800 Medicare to tag the supplier and request a claim hold. She emailed photos and a 1-paragraph statement. Unsolicited device, unopened, refused. She also asked the supplier for the signed order, visit notes, and proof of delivery. They couldn't produce a signature or face-to-face documentation, just a template note. Payoff, claims reversed, $3,200 wiped, supplier blocked in her plan profile. The quick win clicked because she had clean refusal proof and reported fast, so the billing run died early. Story B, lab panel loop closed. Dennis, 74, noticed a repeating lab G-code every other month, genetic screening panels he'd never authorized. Why it mattered? Labs can add thousands and legitimize future DME with a paper trail. He applied the 3-line MSN audit. Who billed what code? When? The provider was in another state. Dates didn't match any appointments. He called the lab and requested the ordering provider's signed requisition and visit notes. They sent a generic televisit summary with 0 exam and no risk factors. Dennis circled the lines on his MSN, filed with SMP, and submitted a CMS fraud complaint with the requisition and note attached. He asked Medicare to place a program integrity hold and alerted his Advantage Plan's SIU team. Then he called his PCP and placed a chart note. No outside labs without PCP order. Payoff. The lab refunded, the ordering provider was sanctioned by the plan, and the repeating G-code vanished. The shortcut nobody teaches. Demand the requisition plus notes. Without a named ordering clinician and a real medical rationale, these panels are easy to unwind. Story C, scooter trial turned around. Eileen, 79, got pitched a free mobility evaluation. A week later, a scooter appeared on her MSN as a rental with a plan to convert to purchase. She never rode one. Why this mattered? Capped rentals stack month after month and can block future mobility devices. She moved fast. First, she asked the supplier for proof of delivery, the order with HCPCS code and modifiers, and the prescribing notes. They sent a drop-off photo at her porch, but no signature, no acceptance. She filed refusal evidence from her door kit on a second attempted delivery. Label photos, refused written on the box, and a carrier pickup scan. She also pressed on the RA angle. The supplier hinted it replaced a prior device. She wrote back, provide incident date and documentation of loss or irreparable damage to support RA. They had none. Eileen submitted a Level 1 redetermination within the 120-day window with her doctor's necessity letter, diagnosis, failed conservative care, and no prior scooter use, plus the porch photo mismatch and refusal scans. She asked her hospital DME for a loaner while the appeal processed. Payoff. Denial overturned, rentals reversed, and her legitimate mobility evaluation proceeded through her PCP with correct documentation. Now, the pattern across all three. Why these wins happened. Each person linked their MSN audit to immediate documentation and reporting. They didn't wait for annual summaries. They acted within days. What they used, the same toolkit, photos of labels, tracking pages, short sworn statements, SMP and Medicare case numbers, and targeted document requests that mills struggle to answer. How they framed it: calm, repeatable scripts. Unsolicited DME, refused unopened, no prior consent. Send provider notes, order, and proof of delivery. And when RA or replacement language popped up, they demanded the incident proof that almost never exists. Common mistakes they avoided: they didn't open boxes just to look. Sealed plus refused kills charges. They didn't debate medical necessity on the phone. They requested documents and logged reference numbers. They didn't rely on a single report. They triangulated Medicare, SMP, plan, or DME MAC. The payoff you can expect when you follow this: faster reversals, shorter billing runs, and cleaner benefit windows. And here's the surprising upside. Once suppliers see your binder, the sentinel effect kicks in. Documented refusals, case numbers, and requests for sign notes push mills to drop your number and move on. If you remember nothing else from these stories, remember the flow: MSN 3-line scan, refuse and document, report, and request notes, then redetermination with proof. That's how you turn a scary bill into a quick win. Belief, breaks, myths that get seniors hurt. Let's clear the 4 myths that keep people stuck, because believing any one of these is how the billing run keeps going. Myth 1: if Medicare paid, it must be okay. Payment is not approval of truth, it's approval of paperwork. Claims systems process millions of lines based on whether required boxes are checked, not whether a human actually needed the item. Mills know this and build notes that look adequate. That's why you can see paid claims for a brace you never wore or oxygen you never used. The fix is simple: monitor like a bank account. When you flag a bad line and force documentation, order, notes, proof of delivery, weak paperwork collapses fast. Myth 2: it's free, so it won't affect me. The price tag at checkout isn't your only cost. DME lives on replacement clocks. When an E-code posts, your record shows you've already received that category. Same or similar rules can lock you out for 13 to 36 months, and many items carry a 3 to 5 year useful lifetime. So the free back brace today can block the exact knee brace you actually need next year. Your money loss is secondary to the treatment delay. Don't think price, think benefit window. Myth 3: I can return it later if I don't want it. Billing clocks start at shipment, not when you decide. If you open the box, assemble it, or sit on it for a week, the supplier argues acceptance and use. That makes reversals harder and lets refills sneak in. Your move is refusal at the door. Sealed box, refused. Unsolicited DME, photos, carrier scan, and quick reporting. That puts the burden back where it belongs and prevents a rental from aging into your file. Myth 4: my doctor approved it. Mills often leverage a leased NPI and a teletemplate to spoof medical necessity. That doctor isn't your PCP and probably never reviewed your chart. You're allowed to ask for the visit notes and the signed order. If the note is 30 seconds of generic pain language without exam detail, that's powerful evidence for redetermination and fraud reporting. Your own doctor's letter, diagnosis, failed conservative care, and no prior device outweighs boilerplate. Here's the checkpoint: payment isn't proof, free isn't harmless, return later isn't protection, and doctor approved isn't necessarily your doctor. Replace myths with habits: MSN 3-line scan, door refusal, document requests, and fast reporting. Once you run those on autopilot, scammers lose leverage. And when you do need real care, your record is clean, your benefit windows are open, and your appeal packet wins on paper. Now that you've got the belief breaks, let's put them into a routine you can run in minutes each month so nothing slips by. Checklists: monthly, quarterly, annual. Here's the no-drama system that keeps your benefits clean. 3 checklists: monthly, quarterly, and annual. 15 minutes a month, 20 minutes a quarter, 30 minutes a year. That's it. Monthly, do the MSN 3-line scan. For every line, who billed, what item code, when shipped or dispensed. Circle anything unknown, out of state, or duplicated. Add each suspect to your unknown provider list with the date and dollar amount. If you see DME E-codes you didn't receive or lab G-codes you didn't authorize, call the supplier and request order, provider notes, and proof of delivery. No debates, just documents. Then call 1-800-Medicare to log a potential fraud tag and contact Senior Medicare Patrol to open or update your case. If a box arrives, trigger the door protocol. Sealed, photos, refused. Unsolicited DME carrier scan, and one supplier call to log refusal. File everything in your binder the same day. Also monthly, review your phone defenses. Confirm unknown callers are still blocked on your cell. On landlines, keep call screening on. Add any new suspicious numbers to your do not answer list. Refresh the script taped to the phone. I don't confirm Medicare information by phone. Remove me from your list. Mail official notices. Only. Repetition builds reflex. Quarterly, run a deeper check. First, verify no active DME rentals you don't recognize. If you're on Medicare Advantage, call Member Services and ask them to read back your current DME authorizations and rentals. On Original Medicare, use your online portal or call your DME MAC to ask if any capped rentals are active under your MBI. Pay special attention to oxygen rentals, E0424 and E0439, and mobility devices. If you find an active rental you didn't authorize, open a dispute and request documentation immediately. Second, do a 5-minute SMP touchpoint. Email your case handler with a brief update, even if it's no new activity. Visibility keeps pressure on mills. Third, reconfirm pharmacy settings. Ensure auto ship remains off except for the meds you approve, your verbal PIN is active, and no new prescribers were added without your say-so. If you use caregiver help, verify their authorization is current and that they've run the monthly MSN. Scan. Finally, refresh your PCP guardrails. Send a quick portal message that restates your chart note. Tell a DME only via PCP referral. No third-party orders without evaluation. Ask that it remain on your problem list or a prominent chart flag. If you changed plans or providers, make sure that note got copied forward. Annually, do your benefits reset review. Block off 30 minutes. Step 1. Scan the last 12 months of MSNs for any missed oddities. Anything new gets circled, logged, and if needed, reported. Step 2. Check your plan or Medicare settings. If you're on Advantage, confirm DME requires in-network PCP authorization and that any known bad suppliers are blocked on your profile. If you're on Original Medicare and had repeat fraud, consider requesting a new Medicare card and number backed by your FDC report and SMP case. Step 3. See your PCP for a device needs check. If you already use supports, cane, brace, oxygen, confirm they're still appropriate, document the plan, and get a fresh note that can support renewals. Ask your PCP to print an after-visit summary showing your DME guardrail note and your current device list. That summary helps when a denial pops later. Step 4. Tighten your communications. Purge phishing emails from your inbox, update your spam filters, and review what health portals you've connected. Remove any you don't use. Step 5. Tune the home kit. Replace dead markers, reprint your refusal sticky, and restock printer paper so photos and tracking pages get printed fast. Add 2 situational plans. Travel plan. The week before a trip, pause refills and shipments. Tell your pharmacy you'll approve nothing while away. Family plan. Designate a helper, get HIPAA and plan rep authorizations on file, share your scripts and binder location, and assign a fixed day, say the first Saturday, to run the monthly scan together. Now you try. Put the next MSN day on your calendar. Tape the phone script. Build the front door kit. These tiny, boring steps stack up to big wins. Shorter billing runs, open benefit windows, and fast approvals when you need real care. And yes, suppliers notice. The sentinel effect is real. Visible oversight makes mills move on. Caregiver mode, protecting parents without overwhelm. If you're the one helping a parent, your job isn't to fight every battle. It's to build a light system that runs in minutes. Start by getting permission in place. Ask your parent to sign 2 forms, a HIPAA release at each doctor's office and a plan representative authorization with Medicare or their Advantage plan. Without those, staff can't talk to you. Put copies in your binder and save PDFs in a shared folder. Create a shared inbox. The simplest move is to forward their MSN emails and plan notices to a caregiver email you control. If they don't use email, set up online accounts for Medicare and the plan with their permission. Then enable alerts to your inbox. You want eyes on every claim line without digging through mail piles. Now, craft caregiver call scripts. Tape 2 short lines near their phone and yours. We don't confirm Medicare or personal info by phone. Remove this number from your list. Mail official notices only. No device orders. All DME must come from our PCP after an appointment. Teach them to hang up after saying it. Your role is to return calls only to known numbers on the card or portal. Build a supplier whitelist with the PCP. Message the doctor. Please add this to the chart. Tele-DME only via PCP referral. Approved suppliers. Hospital DME, local pharmacy. Block all others. Ask for the after-visit summary showing that note and file it. Share the whitelist with your parents' plan so authorizations route correctly. Set a weekly 10-minute routine. Same day, same time. Open the latest MSN or plan EOB. Run the 3-line audit. Who billed, what code, when shipped. Add anything odd to the unknown provider list with dates and dollars. If a red flag pops, you, not your parent, make the 2 calls, supplier for order/notes/proof of delivery, and 1-800 Medicare or the plan to log a fraud tag. If a box arrives, you run the door protocol. Leave sealed, label refused. Unsolicited DME, photo label and tracking, request a refusal scan, and add it to the binder. Centralize contacts so helpers can step in. Front page of the binder. Medicare Plan Fraud Unit, SMP, PCP, Hospital DME, Pharmacy. Next page. Your parents' Medicare number, plan ID, and your authorized rep confirmation. Keep a 1-line summary of current devices so anyone can answer. Do you use oxygen, braces, scooters? Without guessing. Tighten phones without isolating them. On their cell, whitelist family, PCP, pharmacy plan. Enable silence unknown callers so spam goes to voicemail. On landlines, turn on call screening that asks unknown callers to state their name. Review voicemails weekly. Return only calls from trusted sources. If a spammer slips through, add the number to a shared do not answer note. Handle meds and refills. Call pharmacies to disable auto ship except for items you approve, add a verbal PIN, and require your confirmation for any new prescriber or device. If they travel or move between homes, pause shipments the week before and resume when they're back. Make it shareable. If siblings help, give each the scripts, the weekly MSN slot, and the binder location. Divide roles. One handles calls, one handles the inbox, one keeps the door kit stocked. Keep a simple log so anyone can pick up where the last person left off. Your North Star is calm repetition. Scripts by the phone, a 10-minute MSN scan, sealed box refusals, and fast reporting. Done weekly. This keeps benefit windows clean, shuts down mills early, and protects care without burning you out. Advanced defense. Repeat target protocol. If you've been hit twice, treat it like a break-in pattern, not a one-off. We're going to harden the target so future attempts bounce. Start with your number. call 1-800-MEDICARE and request an expedited replacement Medicare beneficiary identifier due to repeated medical identity misuse. Use your case numbers to justify urgency. Ask the rep to confirm when the old MBI will stop accepting new DME claims and how they'll route pending reviews. When the new card arrives, update your real providers one by one so nothing gets lost, and keep a log of who you notified and when. Next, shine a light on repeat offenders. File a CMS complaint naming the suppliers, include dates, claim lines, and all reference numbers from Medicare, your plan, SMP, and the FTC. Concise matters. Unsolicited DME, refused unopened, no prior consent. Supplier failed to produce signed order, face-to-face notes, or proof of delivery. Attach your photos and refusal scans. Investigators act faster when the pattern is documented and cross-referenced. Tighten your clinical gate. Message your PCP to add a stronger chart flag. No DME except after in-person evaluation. Tele-DME only via PCP. Referral. Ask for an after-visit summary or portal confirmation that the note is active and visible to staff who handle orders. That way, if a mill sends a faxed order, your front desk sees the red light before anything goes out. Now, block the noise at the source. Use call screen tools that force unknown callers to state their name before your phone rings. Enable silence unknown callers on your cell. For landlines, turn on your carrier's call block and add a whitelist. Consider a third-party screening service that flags high-risk VoIP ranges. Most mills live there. When voicemails do arrive, you return only calls to the numbers printed on your plan card or provider portals. Protect the financial flank. Medical identity theft often rides with standard identity abuse. Freeze your credit at all 3 bureaus. Create an online Social Security account if you haven't, and set up two-factor authentication. This doesn't stop Medicare-specific fraud, but it blocks the paired attempts that come after a data sale. Escalate with your plan or DME MAC. Ask for a program integrity note on your profile. Do not process DME claims from unknown suppliers without phone verification. For Medicare Advantage, request an SIU review and a member-level block on the named suppliers. For Original Medicare, ask your DME MAC how to tag your file. So suspicious E-codes route to review. If you've got a caregiver, formalize it. Add them as an authorized representative with Medicare and your plan, and give them the scripts and binder access. Assign roles. One person handles calls, one handles MSNs, one manages the door kit. Consistency is your shield. Finally, adopt a 24-hour reflex. Any new red flag, MSN line, call, or box, triggers action the same day. Document, refuse, report. Mills thrive on delay, rapid, repeatable reactions, end runs early. After 2 clean months with no new attempts, keep the defenses on. The goal isn't paranoia. It's predictable protection that takes minutes, not hours. Implementation/payoff. 3-step action plan. Here's the quick start that locks this in today. Step 1. Do a 15-minute MSN 3-line scan. Who billed, what code, when shipped. Circle unknowns. Add them to your unknown provider list. And open an SMP case. Step 2. Build your front door kit and phone script. Marker, tape, refusal sticky, and I don't confirm Medicare info by phone. Remove me. Put both within reach. Step 3. Lock tele-DME behind your PCP. Message your doctor to add the chart note, and call your plan to require PCP authorization for any DME. Do these today, and you cut billing runs short, keep benefit windows open, and get real care approved faster. The big takeaway: treat your Medicare number like a credit card and run the same routine. Scan, refuse, report, and request notes so free devices can't burn your benefit windows or block your care. If you want the exact denial override play to unlock care when same or similar shuts you down, Watch the denial guide next. Subscribe for practical protections like this, and set your MSN day on the calendar before you close this video.